part with Professor Erica Mendoza, and the mic is yours, Erica. So you can see now the duplex screen and Professor Erica in her clinic, and we have very kind patient that would like to thank him very much for helping us. We
Okay,
can see
thank
your
you
screen,
so
Erica.
much.
Yeah.
Do you hear me? Yes?
Yes, we can hear you very well.
Yes. A bit von davon? Yeah? Okay, so this is Miss Balchi, a patient with varicose veins, not so many. Do you speak English? A little bit. Okay, good. I sometimes will change to German. Kann sich einmal hinstellen? She has wonderful legs, as you may see. Haben Sie Krampfadern? And yes, let's show them. This ones. Do you see these? And the varicose veins are not so much, like here and there. But you will be surprised, and here is a little tributary. We'll put this light on. Here is a little tributary, yes? And she came asking for cosmetic help. And as always, before I do this, I make an exploration of the veins inside. So I have put now the jelly on my, and I start in the groin, right leg. You see everything?
Yes, we can see.
Yes.
This
is the
common femoral
cross-section.
velia, Mickey Mouse appearance.
Perfect. Mickey Mouse. The Mickey Mouse im Bein, gucken wir mal. The Mickey Mouse, the artery, and the artery. She's alive. Yes. There is a. And this is the deep vein. Let's go with the deep vein first. I make the calf compression at yes, you have calf compression, decompression, and we can make another thing. Heben Sie mal die Zehen vorne an. And, genau, again, perfect. This was the Wunsthof maneuver. And as you are seeing while I'm doing it, we see two things. When we look at the leg from the outside, we would think there is not so much happening inside. But if you see this vein is rather large, we can measure it. It's larger than expected at that point. These are 7 millimeters, which is like the edge to being too large. And we have, I tilt the probe to the top. We see here an epigastric vein joining from lateral or a circumflex perhaps. This is the great saphenous vein. We go down, this is another vein coming from medial, the pudendal vein possibly, joining in. And now I go down and we see what we have asked now perfectly. This is the great saphenous vein covered by the fascia and on the muscle fascia. This is the wonderful saphenous vein. And attention, this is the large vein like Mohammed said just before. Here is the saphenous vein covered by the fascia, and here is the large tributary outside the fascia. This is a wonderful image, and we will start doing here manual compression. This is over. And you see reflux in the tributary here, but we will make it bigger, okay, but not in the great saphenous vein.
Yes, that's very nice, because you can see Professor Erica diagnose reflux by color, and this takes experience. You don't need to put Doppler probe, but you can see the color, the upthrust and the reverse of color, and how long duration. So you can know reflux just by color.
Yes, but if you want to make a documentation of the reflux, you always have to do it with, you know, now I'm measuring in the saphenous vein here and showing there is no reflux. And when I go inside the tributary, You see a long-lasting reflux
That's
in
a
the
grade 3
tributary.
reflux, yeah, more than 2 seconds. Would you consider what is normal is less than half a second reflux? Is that normal?
I think normal is less than 0.5, but this doesn't mean that reflux means more than 0.5. For me, reflux is more than 1 second.
Okay.
Because 0.5, more than 0.5 second is very, very short.
Okay.
Now we come to what we are here to learn today. Einmal die Zehe heben. She will, and wieder runterlassen. She put up the toe and lowers it. And if you see this very slowly, I make the same in longitudinal, danke sehr. In longitudinal aspect, let us find the junction. Here you have the junction.
Yes.
This is the femoral vein, yes, and this is the valve place. I like to put it all in one image. This is better.
Yeah,
yes.
That's great.
And now lower the end down, and you see very, very clearly that the reflux is not coming out from the deep vein. Look, in the systole, it flows from the superficial to the deep.
Yep.
And in the diastole, it is not coming out from here. This means the terminal valve is competent, very, very obviously.
Yes.
And so we have to find where this reflux is coming from. And I go up to the epigastric vein. Einmal die Zehe heben und runterlassen. And here, it is not so clear, because as we know, in the epigastric vein, the normal physiologic flow is down.
Yes.
And so this one is just a short, about a second. So I won't be so sure that this is the correct reflux source. Sorry, I will try this one. Einmal die Zehe heben und runterlassen. It's not as clear. So now we will make another thing. We will look in color, which sometimes helps. And we see, like, it looks like a little bit comes from the deep vein.
Yes.
Yes, here. Sometimes it comes at the border. So I would say, perhaps it's the deep vein. I would re-investigate. Yeah. You always have to look at the patient if it's. Now, the longer she's standing, you observe here, the longer she's standing, nochmal die Zehe heben und runterlassen, the thicker the vein gets, and now you see it would be possibly coming from the deep vein. Sometimes it's not as clear.
Yeah.
Yeah, yes, you saw that.
Yes,
but
yes, very
normally,
clear.
I will make the comparison. I make half compression and release. And now we wait a little bit to the system refilling. Now elevate the toe on release. And you see the curves are more or less the same. Yes, and
Yes.
my experience is if you have a real large reflux from the deep vein, we will have a patient afterwards. This curve is usually the same height than this one. So you have a big volume coming quickly. If you have like a paraosteal reflux, you can have this situation that the curve is flat and long-lasting. Just to make the... Yeah, do you have a question?
Yeah, we have a question. Someone said, can this be due to pelvic congestion syndrome, or this is unlikely to have a connection
You have
between?
to...
Yeah.
I mean, the pelvic congestion syndrome is not an ultrasound diagnostic, but it's a clinic diagnostic.
Oh,
This is a pelvic
excellent.
reflux.
Yeah.
It is, of course, a pelvic reflux because if it comes down the epigastric vein, it is pelvic.
Yeah.
But the congestion syndrome means dyspareunia and pain and so on. So not every reflux coming down the pelvic veins is a congestion syndrome.
Excellent.
Yes?
Yes, that's very clear.
So now we have here the saphenous vein, the tributary. We go down the saphenous vein, which is really, really tiny, 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 perfectly healthy. Perfectly healthy, healthy, healthy. There it is. Very, very little. We just check. It doesn't talk to us nearly because it's so healthy.
Yeah.
Yes. Perfect.
So this is
And
an ideal case for Chiba, isn't it?
this is an ideal case for Chiba. And you know what I would do with if I do Chiba? I mean, sorry, every case is an ideal case for Chiba.
Yes. Yes. Very
You
sorry,
were
Erica. Yes.
misguiding me.
I will rephrase it. So this is one
Yeah.
of the totally all very good cases for Chiba. Yeah.
Yes, yes.
Okay.
And
So
now you see what I mean. You look, this one is the saphenous vein interfascially.
yes.
Here is another vein coming. Just stop and have a look. There is a vein joining in.
Yeah.
And this one is also having a reflux, as I suspect now. And this one is an obvious longer than 1 second reflux.
Yes.
And you can
So you have two refluxing tributaries going to great saphenous vein, which after the mid-thigh, it looked like a normal vein.
yes. So we have one reflux coming from the epigastric
Yes.
and one going a little bit down from the accessory posterior vein, which usually comes from the pudendal labial veins.
Yeah.
But going back to Chiva, so here you see where the vein goes superficial. Yes?
Yes, you can see it very
And-
well. We can see
And
your
if you
duplex
make
scan, how you
longitudinal,
perform with the patient by two views. That's beautiful.
so we have the saphenous vein with a caliber change. This one is thick. This one is very tiny here. Yes.
Yes.
And you have this one is a tributary. If you make Chiva in this situation, terminal valve nearly competent, you will make the following. Wait. Geben Sie mal die Zehe an und runterlassen. If you see the finger here, Mahmoud, your turn, yes? I
Yes.
close the tributary with my finger.
Yes, I
Yes?
can see your finger
Geben Sie
closing
noch mal
the
die Zehe.
tributary. Yes.
Runterlassen. There is no longer a reflux.
Excellent. So you know the source of the reflux.
And I saw the drainage pathway. So if I do Chiva, I would just close the tributary
Yeah.
and then get the great saphenous vein competent again. Attention, einmal Zehe heben, runterlassen. No reflux, I lower the finger, reflux. So if you close the vein exactly here,
You get the
this level,
great saphenous
Yes.
vein back again, refluxing.
get it back to anterograde flow. And in this case, you can do that also with endoluminal laser because this vein is normally the tributaries are tortuous.
Yes.
But in this case, it is a very straightforward tributary.
Yes.
Yes?
Yes.
You can put the needle inside the tributary like here. Yes?
Yes.
You can introduce the needle, go up with a laser device until this point and close here so that you
Yes.
leave the great saphenous vein draining. This is one of the best situations for Jiva. Thank you for introducing the questions. Let's have a look at the other leg. You know,
Oh, we got another question. Do you like laser or foam sclerotherapy? What do you prefer and why?
it depends on the situation.
Okay.
In this case, I would do either surgical, just flush ligation of the tributary on the saphenous vein,
Yeah.
or laser, because in both cases you're sure to close just where you want.
Yeah.
If you put the foam, you risk to close all the saphenous vein because you can't stop the foam going up. If the vein was more tiny,
Yeah.
yes, if it was smaller,
Yeah.
then I would imagine to do ultrasound guided foam therapy.
Yeah.
But this is a large vein.
Yeah,
Yes?
the problem with foam, you cannot control how much segment it will treat. So here,
Yes.
you can pinpoint what do you want to occlude, and laser would be an ideal with a small fiber, laser fiber.
Yes. So
Excellent.
you can with the laser fiber you can be more surgically, more exact. Yes.
Yeah, yeah.
So
If you want to
this is
lower
the
the pulse
other.
down, yeah.
Yes, this is the left groin. And on this side, the lady has an accessory anterior vein. If you remember, on the other side, we had no. We come
Yes,
back from the beginning. This one is the artery. This one is the common femoral vein.
yes,
And you have lots of fantastic veins here.
yes,
You have the pudendal going straight into the junction here.
yes,
Yes?
yes,
So this is the saphenofemoral junction. Here you have a common trunk for the accessory anterior, which is going down here. But
yes,
listen, I go up, up, and we have the accessory coming from above. So we have accessory and epigastric joining together into the great saphenous vein, and then we have another epigastric vein coming from medial. So we will make different investigations.
yeah,
Oh, yeah, there you have the wonderful artery crossing. And again, it looks like it doesn't, a little bit comes from the deep vein, but it could be also coming out. No, there is coming out here. We follow the tributaries.
yeah.
Einmal die Zehe heben und runterlassen. This
There
one
are
does, this
few
one,
questions coming in. Whenever you're free, I can give it to you.
excuse me?
There are few questions coming
Oh,
in.
okay.
Okay.
Yes.
One of the
Yes.
question from Bobby Varki. If you close
Yes. Hi, Bobby.
if you close the tip of the tributary by laser, it can reopen after some time, right? This is his question.
It
Recurrence
can
after
happen
laser.
like the GSV can reopen. I mean, that happens after laser, but
Yeah.
it is very seldom. I mean, it's below 1% in my office.
Yeah. Yeah, I think if you destroy the intima with laser, with a good
Yes.
laser, the recurrence also possible, but is very, very slim. And with the recent European guideline for venous disease 2022, laser is the first option for therapeutic treatment. We got another question by Dr. Haydar Aslan, which is a famous doctor from Turkey. Is it possible to use three-way balloon supported sclerotherapy delivery system to control which level you can close under duplex ultrasound? This is a new
This is
device
good.
where,
This is a
yeah,
very good question.
yeah,
Because let me just finish something I want to show.
yeah, please.
Yes. This is a good question. I use, when I really want to make it with foam, I use the so-called dry foam, where you put only one part of liquid and 7 parts of air.
Okay,
Normally you make Tessari, which is 1 to 4.
yeah,
And if you use 1 to 7, the foam is like very viscose.
yes,
And you can control better the extension. But nevertheless, if you want to preserve the saphenous vein, and this is what we try to do in Chiva,
yeah,
you shouldn't handle with foam next to the saphenous vein.
yeah, yeah,
Yes, so
yes,
I just want to use this situation just a moment,
yeah,
just do one maneuver. You have seen, this is the reflux through the saphenofemoral junction,
okay,
and when I go below, there is less reflux, and it's like, I don't know exactly where the reflux comes from. So we are going to make a dependency maneuver. Legen Sie
okay,
sich mal einmal hin und machen mal das linke Bein in die Luft. Right, from here you can, okay. So she's having the leg in the air. Yes, very sportive.
for 20 seconds, yes,
So while she's having the leg in the air, another question.
yes.
Do you have another question? No.
Yes, we have
So-
another question. We have plenty of questions. Do you
Okay,
prefer laser or radio frequency in your experience, or is there a difference?
Yes, that question is too long to be answered. Just so I come back to that.
Okay.
So now einmal bitte hinstellen.
Okay.
Now lady is coming back to standing, and now look. it takes and takes and takes and flows and flows. You see what I mean? It fills and
Yes.
fills and fills.
That's a very
And if
good
you
demo.
put the
Very good demo.
and if you put the color, you can very well look. Here you see flowing, flowing, flowing. This tributary is guilty. You see that?
Yes. Yes, very clear.
It is flowing, flowing, flowing. It's flowing, 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 flowing. So sometimes it takes a time to do it, but it clarifies perfectly where the flow comes from and where not. So let us
Yes.
also have a look at this accessory posterior. There is none.
So this is a
No,
great
but in,
test to tell you where is the reflux is coming from and how
yes,
you manipulate your treatment to tackle it without affecting great saphenous vein.
yes. So this one is also an incompetent posterior accessory, but I think we have seen most of the reflux also after laying down and standing
Yes.
comes one from the deep vein, obviously. Yes, you see here,
Yes.
you see in the color, you see that best. It comes
Yes.
out
Yes. Very
here,
clear.
and one comes from this accessory, from this epigastric vein here. This is also filling the leg.
Yeah.
And
From
this is my
from your experience, when you treat these two tributaries, the big great saphenous vein that we see here will shrink in size, become normal again?
yes. I have, I mean, in this case, where the terminal valve is semi-competent,
Yeah.
I would, and I only treat the tributary. If I could foam just this one, yes,
Yes.
this would be effective only if the terminal valve is really competent.
Okay.
Yes. So in this case, or in both legs, as we have a reflux from the deep vein, I would close in this case because it's a young lady and I don't want to have, I want to be cutting the leg and so on. I would close this great saphenous vein below the terminal valve, or do what, again, in this case, if we look at here, at this, we have, again, the saphenous vein, the tributary going out the fascia.
Yeah.
Here we have a little perforating vein, which is great.
Yeah.
Have a look. It's so healthy that it doesn't talk to us. But again, I would close the tributary at this point of the inner thigh, where it comes out the saphenous vein,
Yes.
because I will make an experiment with you if we can see it in ultrasound. If I close it a little bit further down, let's have a look. Here it is. Oh, give me a second. Heben Sie mal die Zehe und runterlassen. I don't know if I'm at the correct place. Here. Okay. Mal Zehe heben, runterlassen. You have a reflux there.
Yeah.
And if I close the tributary further down, mal
Yes.
Zehe heben, runterlassen. You have no longer reflux here until you open the vein, which is connected tubes. I mean, this is physics.
Yes.
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 But this demonstrated if all the reflux goes out the saphenous vein in one tributary, if you close this tributary, you will have a recovery of the proximal saphenous vein.
Yes. That's a very